Hello, everyone. Today, we'd be starting off with health psychology. As you all must be aware that there are two components that we all need to cover for our preparation for A-level psychology. And they are number one, psychology, clinical psychology. The first one is clinical psychology. And the second one that I choose to teach is health psychology. Now, when we get started with health psychology, there are 5 different units that we need to prepare from. And they are number one, the patient practitioner relationship. Number two, adherence to medical advices. Number three, we'd study about pain. Number four, stress. And the fifth one is health promotion. Without any further ado, let's get started with this. Now, each component that we have has 5 different units in it, right? Each component has 5 units. And when I use the word unit, I'm referring to a chapter. And each unit has 3 different sections. So these are the 3 different sections that we have for patient practitioner relationship. The first one is practitioner and patient interpersonal skills. The second one is patient and practitioner diagnosis and style. And the third one is misusing health services, right? Now, this is what we'd be covering today. Patient and practitioner and patient interpersonal skills. You all should remember, you all should know that for every component or every chapter, there's just one key study, right? And along with that key study, we have several other example studies as the examiner refers to it. So I'll just highlight this with the color yellow. So we have these two example studies that we need to cover today. Now, what is this about? The patient-practitioner relationship. When we use the term, when we talk about patient-practitioner relationship, a patient is a patient. And when we use the word practitioner, a practitioner can be any medical professional. Any medical professional could be a doctor, could be a nurse, or a pharmacist. In this context, we're mostly talking about a doctor here. This could The doctor could be a general practitioner or could be a specialist, right? So getting started with this, when we talk about the relationship between a patient and a practitioner, I'm sure you'd all agree that there has to be some rapport to be developed between the patient and the practitioner. The patient needs to feel comfortable enough to be able to discuss his or her problems or illnesses. Likewise, the practitioner needs to adapt to certain practitioner styles that we'll of course discuss in the next section. But the practitioner also needs to be skilled enough to understand what the patient is trying to explain. Now, when we speak about the patient practitioner relationship, we also need to remind ourselves that communication, it's the communication between the patient and the practitioner that plays a very important role, right? When we talk about this communication, we would broadly divide this into 2 main categories. To name them, we initially speak about non-verbal communication, and number two, we speak about verbal communication, the difference between non-verbal and verbal communication. Now, when we speak about non-verbal communication, my dear, so nonverbal communication could be anything from your body language to your eye contact to your demeanor to your voice, to not your voice would be a part of verbal communication. So verbal communication has to do with your body language, has to do with your facial expressions, your eye contact. Along with that, the factor that we'll be discussing over here today under the study that was conducted by McKinlay and Wang, that's an example study, has to do with the attire of the doctor. The attire of the doctor, or what the doctor wears. To what extent do you think the attire of the doctor matters when it comes to the patient practitioner relationship, or when it comes to when it comes to when it comes to the patient holding an opinion about the practitioner? In other words, what I'm trying to say is, would a doctor wearing something casual be taken seriously by the patient or not, right? Question mark. To begin with, now, when we speak about nonverbal communication, according to Argil suggests that nonverbal communication could have 4 major uses. Number one, you could use nonverbal communication to assist speech, right? Now, nonverbal communication is used to assist speech. I just realized I'm moving my hands, right? So this is, I'm trying to, when I'm emphasizing on something, when I'm trying to regulate a conversation with someone, your nonverbal communication could have a lot of impact. One. Number two, non-verbal communication could be used as a replacement for speech. For example, any gesture, any raised eyebrow, Number three, nonverbal communication could be used to signal attitudes too. For example, we might try to look cool and unworried by taking a very relaxed and a standing position. Number four, to signal emotional states. We can usually tell when someone is happy or sad, tense by the way they're sitting or the way they're standing, right? So these are all examples of nonverbal communication. Yes, I am aware this reference that I just tried explaining you all by Argyll in 1975. This is not mentioned in the syllabus. If it's not mentioned in the syllabus, you cannot be questioned on this. Nonetheless, you could the knowledge that you gain from this could always be put to use when you're writing answers. Taking this a step ahead, let's start off with the study that was conducted by McKinlay and Wang. So we're studying the study that was conducted by McKinlay and Wang in the year 1991, and this has to do with the impact nonverbal communication has on the consultation, right? This has to do with the impact nonverbal communication has on the patient-practitioner relationship. It is pretty important that in a medical consultation that there should be a good rapport between the health worker and the patient, the health worker as in the practitioner in this context. One of the first things that we notice and make judgments about in any situation is what people look like. So it is probably important to take account of these first impressions. So what people look like, your attire plays an important role in terms of explaining this to you, right? Now, this study, my dear, that was conducted by McKinlay and Wang, we would talk about how what a practitioner wears, how what a practitioner wears eventually ends up affecting the relationship he or she holds with the patient, right? Now, McKinlay and Wang investigated doctors' clothing as a form of nonverbal communication. McKinlay and Wang investigated doctors' clothing or their attire as a form of nonverbal communication. A total of 475 patients seeing 30 different doctors from 5 general medical centers in one area of Scotland. Now, it is pretty important that we try picking on the evaluative aspects while reading through this, right? So there were 475 patients that were studied. So if you're collecting data from 475 patients, of course, this sample isn't very small. One. Number two, they were seeing 30 different doctors. Now, when we talk about you seeing 30 different doctors, that means you have a variety of people, a variety of practitioners that you're getting getting hold of this data from. They were from 5 general centers in one particular area of Scotland. Now, they were from 5 different centers, which is a good thing. But then again, all of this data was collected from one particular area in Scotland. So if we talk about the data being collected from one particular area in Scotland, don't you think this could affect the generalizability of the findings? Of course it would. Now, for instance, if you're collecting data from medical centers that are in an affluent area, in a richer area, in a wealthier part of Scotland, the patients that you'd come across, they might be responding in a different manner as compared to patients from as compared to these medical centers being in a poor or a disadvantaged area. So keep these evaluative aspects in mind. Now, a total of 475 patients seeing 30 different doctors from 5 general medical centers in one area of Scotland. They were interviewed. Interview, my dear, is an example of a self-report measure, right? It's an example of a self-report measure, and all the advantages and the disadvantages of a self-report measure could be applied over here when you're evaluating this, right? So they were interviewed about their opinions based on 8 photographs. The images were of male doctors as well as female doctors, each dressed differently but in a similar pose, right? So if the doctors, they were if the pictures that were shown to the patients, they were clicked in a similar pose, this shows the amount of controls that you have. The more controls you have, the more you'd add on to the validity of your findings, right? Now, they were asked which doctor they would feel happiest seeing for the first time. Do you see quantitative data? This is an example of a Likert type scale. There's quantitative data being collected over here. Quantitative data. And of course, when you talk about quantitative data, Quantitative data is easier when it comes to making comparisons, when it comes to replication, which eventually adds on to the reliability of the findings, right? Now, they were asked which doctor they would feel happiest seeing for the first time, scoring from a range from 0 to 5. Number two, whether they would have more confidence in the ability of one of the doctors based on their appearance. Number three, whether they would be unhappy consulting any of them. Number four, which doctor looked most like their own doctor, right? So, what McKinsey and Wang are trying to figure out at this point is the impact the clothing of the doctor, the impact the clothing of the doctor could have on the view, the opinion, the likability of a particular medical professional or a practitioner in this context. Taking this ahead, finally, they were asked a series of general close ended questions about doctor's dress. The interviewers sampled patients of at different times of the day on 5 occasions at each surgery, seeing an average just over 70% of available patients. We're talking about getting hold of available patients. This, my dear, would be an example of an opportunity sample, right? Now, collecting data at different parts of the day, then again, you are removing the chances that an extraneous variable of, now, for instance, if you're coming across doctors, if you're collecting data early in the morning, you collecting data later in the evening, right? These two instances could have a different response, right? So what the researchers did was they tried collecting data at different times of the day at 5 different occasions. Now, the following results were statistically found to be very significant. Having a look at this, the doctor in a smart suit was the most popular one. The doctor in a smart suit was the most popular one. The doctor in a cardigan and casual trousers scored significantly higher than the doctor in jeans. So, what does this show? Patients preferred doctors in cardigans and casual trousers more than doctors who were seen to be wearing jeans, right? Now, number three, the informally dressed female doctor scored significantly lower than other two female doctors, right? The informally dressed. Now, do you see it's the same female who is posing over here? And the pose is the same, the differences in terms of the attire, the clothing, right? Now, if you have a look at this, we have pictures of male doctors. They're all, it's the same person who's been clicked wearing different clothes. Number four, older patients were more likely to give higher scores to the female doctors in a white coat. This is what we're talking about here, right? Now, the following results were statistically significant, right? When we talk about research is being conducted, we usually take into account the results that are statistically significant, right? Taking it ahead. On this, of the sample of 41% answered yes to the question, do you think you would have more confidence in the ability of one of the doctors? Participants' main choices were: number one, for males, it was wearing a suit, wearing a white coat, a tweed jacket, a jeans, and a cardigan. And for females, a white coat followed by a skirt and a trouser, right? So when participants were asked, do you think you would have more confidence in the ability of one of those doctors? 41% answered yes for this, right? Now, taking this ahead, I hope things are clear over here. Remember, my dear, we're talking about the study that was conducted by McKinlay and Wang. This study, my dear, was conducted in the year 1991. This is an example study. This is an example study from your syllabus. So, yes, this is not the key study. This is an example study. What's the difference between a key study and example studies? Number one, the key study, it's specified in the syllabus, and number two, you have to learn, or you need to be aware of, or you need to know this the key studies in a lot more detail as compared to the example studies, right? Now, nonetheless, if there's any study that is referred to in the syllabus, that is mentioned in the syllabus, you can get questioned on it. Taking this a step ahead, we just spoke about the study that was conducted by McKinlay and Wang. This comes under the heading of nonverbal communication. Over here, we spoke about the extent to which what doctors wear affects the opinion that the patients hold about them, the amount of confidence they have in them, their likability, and the extent to which they believe a doctor's the extent to which the patients believe that a doctor's ability has a lot to do with how he or she dresses up. Now, the adjacent table, we're talking about this table over here. The adjacent table shows that most participants thought a male doctor should wear a tie and a female doctor should wear a skirt. Having a look at this. So this has to do with patients. This has to do with about the male doctor. This has to do about the female doctor. So the ones who believe male doctors should usually wear a white coat, this is 15%. This is for the ones who believe a male doctor should be wearing a suit, 44%, and a tie, 67%. Would object to male doctors if they would be wearing a pair of jeans, wearing earrings, or having long hair. Likewise, when we move on and we speak about the results regarding females, they believe female doctors should usually wear white and should be wearing a skirt, would object female doctors to be wearing a pair of jeans or wearing a lot of jewelry. Now, jeans appear to be too informal and prompted the most objections from participants, regardless of whether a male or a female doctor was wearing them. So this is what we are talking about. If we try to draw a comparison here, have a look at this one and this one. So remember what they objected. What they objected. Oh, sorry, this one. What they objected. Wearing a jeans, right? Now, moving on, let's talk about the strengths and the weaknesses of this particular study. The sample was large, it was a diverse sample, which would, of course, add on to the generalizability of the findings. Nonetheless, we need to keep in mind that all of these medical centers where the data was collected from, they were all from one particular part of Scotland. Having done that, if we move on towards weaknesses, the judgments were only based on appearance. So this could be seen as a reductionist approach. What does the word reductionism over here mean? Remember, reductionism versus holism is one of the issue and debate that you need to know and need to be able to apply when it comes to your A-level psychology syllabus. Reductionism, or the idea when you break something complex into simpler bits, when you're breaking something complex into simpler bits to try to explain what the role of a particular uh, section of what a particular part of that complex thing is, right? So reductionism in this case, let me explain it to you. When you talk about the patient-practitioner relationship, when we talk about communication between the patient and the practitioner, I'm sure you'd all agree that the attire or the clothing of the doctor isn't the only factor, right? When we're referring to this as reductionist approach, it is just the clothing that has been taken into account, right? Yes, clothing does matter. From this research, we figured out, McKinlay and Wang figured out that clothing does matter. Nonetheless, we need to keep this in mind that clothing is just one factor, right? Just one of the non-verbal, just one of the factor that comes in the heading of non-verbal communication that could affect the findings of that could affect communication or that could affect consultation, right? So along with the clothing, it's the eye contact, right? The eye contact. If you go see a practitioner and the practitioner doesn't even look at you, is staring at a painting while having communication with you, would you like it? You wouldn't, right? Likewise, if the doctor, the practitioner sitting with a very grumpy face, the expressions, they matter. And these are examples, these are a few examples amongst many when you talk about nonverbal communication. However, when we speak about verbal communication, the voice, the pitch, the tone, the words that the practitioner chooses to use, these are all factors that, amongst others, that affect the consultation, right? That affect the relationship between the patient and the practitioner. So when McKinlay and Wang, or when this particular research just focuses on clothing, it could be seen as a reductionist approach, right? Now, taking this ahead, we just spoke about the study that was conducted by McKinlay and Wang. Again, let's have a look at Argyll. This would further support the point that I was just making on the towards the end on the last slide. Argyll emphasized that all the various types of nonverbal communication interact with each other. So dress alone will not be enough to create a good communication between the doctor and the patient. A formally dressed, and then we exemplifying this, a formally dressed doctor who avoids eye contact and doesn't use appropriate facial expressions is likely to come across as aloof or distant, and this in itself is likely to be a barrier to effective communication between the doctor and the patient. So again, this point further supports the idea that this study can be seen as a reductionist approach. Now, taking this a step further, let's move on and talk about verbal communication. Now, having a look at what we are supposed to cover for today, this is the first section from the first unit from the first section from the first unit from health psychology, right? The name of the section is Patient Practitioner Interpersonal Skills. We need to study about nonverbal communication with a focus on particularly with a focus particularly on clothing, including a study, an example study conducted by McKinlay and Wang. Number two, we're done with this. Now, number two, we'd move on and talk about the study that was conducted by McKinlay in the year 1975. This study has to do with verbal communication. Look at the difference. This is nonverbal communication. This is verbal communication. Verbal communication with a focus on understanding medical terminology, or the medical jargons. What does the word jargon over here mean? Medical jargon, Jargon. Medical jargon. A jargon is any technical term that the any professional uses. Now, for instance, if I being a teacher, I being an A-level psychology teacher, I very often use terms such as AO1, AO2, AO3. This is a jargon. This is not a medical jargon. Nonetheless, this is a jargon. If someone is an A-level teacher or a student, he or she should know that AO1 over here stands for assessment objective number 1, that is knowledge and understanding. AO2 stands for assessment objective number 2, that is interpretation and application, and assessment objective number 3. AO3 is assessment objective number 3, that is evaluation analysis, right? So this is a jargon. Now, doctors, I'm sure, if I put it in a simple manner, doctors, I'm sure you'd agree, doctors use very fancy words, right? When you're communicating with a doctor, you might come across a doctor who would end up using words that that are very difficult to comprehend. They're very difficult to understand. So sometimes it is hard for doctors and patients to communicate, especially when using medical terms. Most research tends to point out the challenges patients face, blaming them for any issue. Now, according to Simora et al. In 1961, again, I am focusing on this, I'm emphasizing on this, the study by Argyll, or for the matter of fact, by Samora et al. In 1961. These are not mentioned in the syllabus. If they're not mentioned in the syllabus, you will not be questioned on this. Nonetheless, knowing this is good because this would help you write better answers. The more references you know, the better psychological knowledge you would be able to use while attempting your paper. So, Samura et al. In 1961 listed what they called patient deficiencies, like not wanting to hear bad news or having memory problems, and differences based on status, age, or ethnicity. Now, patient definition deficiencies, or the idea that patients, they hold these deficiencies because of which they're not able to understand when the doctor is trying to communicate with them, right? For instance, at times patients, according to many doctors, patients aren't really ready to hear bad news, right? Patients usually have memory problems. Patients usually would understand or would communicate in a different manner based on their social class, their status, their educational qualification, their knowledge on medical sciences, their age, their ethnicity, so on and so forth. So, but maybe it's the doctor's job to make sure patients understand the medical terms instead of putting all the responsibility on the patients. So this is the doctor's point of view. Doctors think or feel that many patients have a deficiency. However, this is when we're taking sides with the patients. And this is when we're talking about the doctors putting in efforts in a manner that they help the patient understand or communicate in a manner that the patient actually understands whatever the doctor wants to, whatever the messages that the doctor wants to get through or come across. Now, taking this ahead, this study that is a part of a syllabus that was conducted by McKinlay in the year 1975. This study, my dear, has to do with verbal communication. Before this, the study that was conducted by McKinlay and Wang had to do with non-verbal communication. This is verbal communication over here. McKinlay in 1975 wanted to explore how well lower working class families, checkpoint number one, we're talking about a particular social class. So the findings from a research from which the findings of the research where you've collected data from lower working class individuals, do you think the findings could be applied on individuals from higher working class individuals? Probably not. In Scotland, again, he understood medical terms. So let me read this out again. McKinley in 1975 wanted to explore how well lower class families in Scotland understood medical terms. To gather a list of commonly used words, the researchers spent a month with the doctors in obstetrics and gynecology wards at a hospital, focusing on terms used in pregnancy and childbirth. I was supposed to highlight this. So taking this ahead, I hope you've understood it so far. To gather a list of commonly used words by the doctors, the researchers, they ended up spending a month with doctors and these different wards, right? Now, taking this ahead, the list of 57 words was then sent to doctors serving the maternity hospital. So the researchers collected the list and they sent it to the doctors serving at the maternity hospital, who marked off any terms they wouldn't normally use. The final list of 13 words was presented to the participants during an interview. So the final list comprised of 13 words. There were 57 words in total. Out of these 57 words, there were 13 that were used finally. So 44 words were discarded by the doctors in the maternity hospital, claiming that they normally wouldn't use these words. Now, the final list of 13 words was presented to the participants during an interview. An interview being used over here, let me remind you again, this is an example of a self-report measure. And yeah, all the advantages and the disadvantages of a self-report measure need to be remembered and to be put to use wherever required. So the words were pronounced and used in sentences, and respondents had to explain what they understood by each term. The words were pronounced and used in different sentences, right? They were verbally told and they were used in sentences. And the participants or the respondents, they had to explain what a particular term or a particular medical jargon actually meant. The responses were recorded, and so if you're recording them, you could always review them. This would add on to the validity, right? So the responses were recorded and two doctors independently scored each response for accuracy. We're talking about two doctors over here. If there are two doctors, we are referring to inter-rater reliability, right? If you're talking about independently, doctors independently scoring this again would add on to the validity of the research. This would again add on to the credibility or the worth of this particular research. The responses were recorded and two doctors independently scored each response for accuracy. Another group of 18 doctors was given the list of 13 medical terms and asked to predict whether the average lower working class mother would not understand at all and admit it, misunderstand the meaning, have an incomplete or vague understanding, or understand quite well. So we're talking about four different categories. Let me number this so that you guys have a better understanding. One, number two, number three, and number four. These were the four different options that were given to a group of 18 doctors, right, who were given this list of 13 medical terms, and they were asked to predict. The word over here is predict. They were asked to predict. They were asked to predict whether the average lower working class mother would, number one, not understand at all and admit it. Number two, misunderstand them. See, admitting it matters over here. There are many instances when the doctors use terms which you aren't aware of, but you don't question back or you don't ask for further clarity because you don't want to sound stupid, right? Or yeah. And another thing that I want you all to keep in mind is, remember, my dear, this study was conducted in 1975. Back then, Probably there was no Google, right? So if we're talking about a study that was conducted 75 years back, it's a study that's almost 50 years old, some 47, 48 years old, right? So the doctors were asked if an average low working class mother would, number one, not understand the word and admit it to the doctor, number two, would misunderstand the meaning, would have an incomplete or a vague understanding of it, or the fourth option would quite well understand. So doctors were now asked what they think about these lower working class mothers, their vocabulary or their grip on medical terms or their grip on medical jargons. It's, doctors use these medical jargons very often, right? What if you're using words that are not understood, right? In that case, the message isn't really getting through. Now, taking this a step ahead, the results indicated that for most words, the scores given by the two doctors were quite similar. Yeah, that shows high inter-rater reliability, high inter-rater reliability. Okay. Now, when comparing the understanding of medical terms between those who regularly attended the antenatal care and those who did not, we're referring to them as the utilizers and the underutilizers, right? Now we're talking about the experience you hold. Now, God forbid, if there's someone in your family, let's just say distant family, who is suffering from any chronic medical illness, you would probably have a better understanding of what it is as compared to someone who does not know of. So your prior knowledge, we're talking about the prior knowledge that people or individuals hold, and in this case, low working class mothers would hold, right? So when comparing the understanding of medical terms between those who regularly attended antenatal care, that is utilizers, and those who did not regularly attend, referring to them as utilizers and underutilizers respectively. Utilizers generally had a better grasp of 11 out of 13 words. Additionally, utilizers who had been pregnant before demonstrated a better understanding of medical terms compared to first-time pregnant utilizers. So what has been found out is the utilizers, or the ones who regularly attended antenatal care, they understood 11 words out of 13, right? The women who had been pregnant before, they had a better understanding as compared to the ones who were pregnant for the first time. These findings suggest that experience tends to increase understanding level, right? The more experience you have, the better understanding you'd have. In comparing mothers' comprehension scores with doctors' expectations, what doctors, remember, doctors were asked over here, 18 doctors were asked, right? They were asked if the words that were typically commonly used by doctors, if the patients would even understand them, right? So these findings these findings suggest that experience tends to increase understanding levels. In comparing mothers' comprehension scores with doctors' expectations, it was found that doctors often underestimated the mother's understanding. Doctors often underestimated mother's understanding. For instance, the term breech, that is related to the baby's position in the womb, was adequately understood by 84% of underutilizers and 100% of utilizers, while doctors predicted only 22% would comprehend it. So doctors are probably underestimating the knowledge lower working class women would have. However, there were three technical terms where doctors expected a higher understanding than was actually found. Although there wasn't enough data for a thorough analysis, it seemed that more senior doctors had greater expectations. So, more senior doctors had greater expectations of patients' understanding than the junior doctors. Another important uh, result that needs to be kept in mind. Another discovery showed a negative correlation. When one variable increases, the other one decreases, or when one decreases, the other one increases. Another discovery showed a negative correlation between the number of words from the medical terms list that a doctor claims to use regularly and the expected patient's understanding level. So, the more words doctors use and the lower the understanding the patients had of this. Doctors often used without expecting patients to understand them. Now, what do we understand from this research? What we understand from this research is that the medical jargons that are used by doctors, doctors need to be cautious. They need to be careful that the patient has a thorough understanding of it, right? Now, taking this ahead, why do doctors use medical jargons that cannot be understood? Probably it makes physicians more appear to be more knowledgeable, could be one point. It keeps the conversation brief, and patients may not ask questions in case they appear stupid. I think that's pretty self-explanatory. Physicians uses them out of habit since they are so familiar with these terms. Out of habit. Number 4, they may feel that the patient doesn't need to know more. The physician may feel that the patient is better off not knowing exactly what the disease is or what its treatment might entail. So these could be possible explanations as to why doctors end up using a lot of medical terms or a lot of medical jargons. Moving on quickly, let's talk about the strengths and weaknesses of the strength and weakness of the study. The transcripts were scored independently with doctors blind to which group each participant was in. So we are talking about more than one doctors. We're talking about them independently scoring this, them being blind about or them not knowing which group each participant was in. This would of course add on to the validity of the study. It also improves the reliability, because remember, my dear, we had data being collected through quanti quantitative means, right? So we had quantitative data. Moving on towards the weaknesses here, the sample was limited in terms of geography and type of participants. Geography, remember, they were all from Scotland. In terms of the type of participants, they were all lower working class females. So the results might not be applicable on um, higher class females, or the results might not be applicable to males as well. This could make it difficult to generalize findings to other cultures as well. Remember, Scotland only. It could also be difficult to generalize to people who use other specialist health services where the comprehension levels may be specific to the medical conditions. Now, I hope this study that was conducted by McKinlay and Wang in 1991 and the study that was conducted by McKinlay in 1975 has been understood. Now, remember, my dear, how do we, since this is the first lesson from health psychology, a few things that I'd want everyone to keep in mind. What is the best way to prepare? See, divide your syllabus into different parts. Like I said, this entire component, health psychology, has 5 different units, and each unit has 3 different sections. In total, there are 15 sections. See section 1, section 2, section 3. Then you have 3 more sections for adherence to medical advices. You have 3 more sections for pain, 3 more sections for stress, and 3 more sections for health promotion. Divide this into different parts and cover your topics one by one. Remember, if there's any study that is mentioned in the syllabus, you can be tested on it, right? After the syllabus changes in 2023, 2024 onwards, now the examiners have introduced a key study, and this key study needs to be studied, and this needs to be known by students in a more comprehensive and a more detailed manner, right? Now, so what I was saying is, how do we start our preparation? Number 1, divide your syllabus into different parts. There are 15 different sections that need to be studied, understood, and then learned, right? Learn it and then write a 6-mark answer, a 6-mark descriptive answer on this. A typical question that students have in their mind is, how much is too much for a 6-mark descriptive answer? It depends on how well you've learned your content, and it depends on how fast you can write. Remember, for a 6-mark question, you wouldn't get anything more than, I mean, you wouldn't get anything more than 9 minutes to write this, right? So it's a 60-mark paper for which you get 90 minutes. For every mark, you get 1.5 minutes, right? According to this calculation, for 6 marks, you have 9 minutes in total. Test yourself, keep your watch, have a look at the time, use a stopwatch, maybe see how much you can write in 9 minutes, right? Now, number 1, know your syllabus well, learn your syllabus, write an answer to a descriptive question, and then if you have a closer look, the syllabus also has very clearly shown us relevant issues and debates that you all could be tested on. Relevant issues and debates and methodology for this topic include: number 1, ideographic versus nomothetic approach; number 2, experiments; number 3, questionnaires; number 4, quantitative data; number 5, generalizations from findings. So Once you're done with your once you're done with writing your descriptive question, start off with an evaluative question, right? And for evaluative question, the easiest way for you to prepare is cater to these bullets that you see, right? Any bullet that you come across, the likelihood that you could probably get a descriptive as well as an evaluative question on this is always there. So yeah, since this is the first lesson, and we pretty much done with what we were supposed to do today, that is knowing this first section, that is patient practitioner interpersonal skills. The next one that we have in line is patient practitioner diagnosis styles, that I try to keep for the next lesson. I hope this was helpful, and do not wait uh, for do not wait before you start preparing for examination. Kindly get started right away. Read a particular section, learn, write an answer, practice, right? The why if you follow this technique, by the time your syllabus would be covered, by the time all of these 15 different sections from 5 different units would be covered, you'd at least know your syllabus. You'd be you would have catered to the AO1 part, that is your grip on knowledge and understanding would be high. So yeah, this is pretty much it for the day. If there's any question, please feel free to ask. Till then, take good care of yourselves. Stay happy, healthy, safe, and protected. Stay humble, spread positivity, spread smiles, and Allah Hafiz.